So I don't know who came first, so I'm going to start with Otis.
Thank you. Otis Brawley, American Cancer Society. Spectacular talks. Thank you, gentlemen. Chris, I'm going to propose why Medicaid patients may not do as well as we would anticipate in your data. Something we found in some of the ACS studies that we've done. And this is a thing that's going to be changing over time with Medicaid expansion, and you may not see it in Massachusetts where you live already. But what we found is that the patients on our databases with cancer who were scored as having Medicaid, by and large, got it sometime about 7 to 14 days after their diagnosis with cancer. And so they had Medicaid for treatment, but they did not have Medicaid prior to presenting with symptoms for the cancer. So they didn't have the ability, women, for example, to go get mammography that was paid for by Medicaid, or if they had a cough, if it wasn't bad, they more than likely would just suppress it and not go get medical help until they were coughing up blood and they went to an emergency room. And we found overwhelmingly that these people got Medicaid after diagnosis. Now, with the Affordable Care Act and the expansion of Medicaid in about half the states of the United States, this might get better. But we're also likely to establish that we're going to have state-by-state disparities that are greater than they actually are. The states that have expanded Medicaid having less disparities than the states that did. And the last point I'll bring up, talking about state-by-state disparities already, we have the situation where in the United States in colorectal cancer, we have a greater than 40% decrease in mortality over the last 25 years. But not in 10 states. Indeed, in Mississippi, there's been no decline in colorectal cancer mortality over the last 25 years. That's not a black-white figure. That's a Mississippi, Massachusetts figure. And in breast cancer, something very similar, except it's 12 states that have had less than a 10% decline in mortality from breast cancer, where the mortality decline in the United States as a whole is over 40%. And indeed, if you let me throw the old Confederacy out of the United States, we could get the breast cancer mortality decline down to almost 50% over the last 25 years.
Thanks, Otis. I just want to add one other thing. Even in Massachusetts, where we've had, this, expanded access for quite some time, when they reviewed the disparities for breast cancer by race, they found that African American women still had this mortality difference, and suddenly a task force was formed because the idea was, with all those hospitals and with all that access, and the screening was equal. So we couldn't say it wasn't access to screening. And I agree that the issue with Medicaid is it's really that it's probably a summary of all the built environment issues that we see there, right? As you mentioned, it's hard for people to come in. And again, even in Massachusetts, there are also some restrictions on when those patients can go where. And that's probably a separate discussion, but that is something our most vulnerable patients are the ones that we put the most restrictions on for where they go. So.
Barry Kramer, National Cancer Institute. So I'm about to ask a highly counterintuitive question. Some people in the room may even consider it an insane question, but the reason why I ask it is that Dr. Lathan said on one of his slides, stage drives mortality. That's a core assumption about what we all think about screening. And it was a pillar of the assumptions that Dr. Wood made. And it even drives many, if not most, of the statistical models projecting out into the future when, in the absence of evidence, the benefits of screening. So I'm going to rephrase it. And my question is, does mortality drive stage? Because if mortality also drives stage, then all of our assumptions are under question. And to an extent, Peter Bach showed that mortality drives stage. There's a term for that. Well, there's biologic predeterminism. That is, The stage at which you diagnose a tumor has a lot to do with the biology, and therefore the risk of death has a lot to do with the stage. And there's a term for it in the world of screening. It is called length biased sampling. That is, tests pick up early stage because they're better at picking up slow-growing cancers. And the extreme form of that is overdiagnosis. To the extent that the arrow or causation is reversed, it calls into question a lot of the assumptions that expert-based panels make, and I'd like to hear comments about that.
Yeah, Martin, I was looking at you and hoping that you would take that on. It's a difficult one to answer directly, except to say that that is a legitimate position of all of the trials about lung cancer screening that were suggestive and suggested earlier diagnosis, earlier stage, and good survival outcomes, but were not randomized, and so did not have the ability to demonstrate a mortality benefit. But I guess I would argue that a randomized trial, the purpose of that is to definitively refute what your position is and that it does demonstrate that there's a mortality benefit of this intervention in the correctly chosen patients. And but I will give a caveat. All of us acknowledge that now that we're doing screening and we have the high sensitivity that we have with the current generation of CT scanners, we are detecting lung nodules, many of which are cancer in the strict sense of the term, but it's likely that the person is never going to die from. And I'll tell you, as a surgeon, I have 1 to 2 conversations a week that are half-hour conversations that are advising a patient of why they do not need to have that lung nodule removed. That is what we should be doing, and that's part of the diminishing of the harms, the unintended harms of lung cancer screening. Is just because we find something doesn't mean we have to do something about it. We're also learning to be smarter about what we do about it, and many of those can be observed for prolonged and potentially indefinite periods of time.
Yeah, of course, we agree. That's why we do randomized controlled trials, because our intuitions can mislead us. But Peter Bach showed that how misleading the intuition actually is in the case of lung cancer, where you can establish survival benefits in a randomized trial, and in the same randomized trial, there's no apparent mortality benefit.
Danny Aberle from UCLA. This is a question again about the shared decision making. I thought it was a particularly creative idea that you had, that we should centralize informed decision making and perhaps have this a federal project. I think that's unlikely to happen in the immediate future. So I wanted to ask you how you address patients who do not qualify, who make it into the program. Do you have physicians who are scheduling screening and then have your program coordinator contact them and unschedule? How does that actually work? What's the workflow? Bill, I'm sorry, I'm talking to you. No.
That one. Oh,
He's a really bright guy, but he's technologically
I don't always wear my
challenged.
glasses. Oh, I see. Okay. I do when I read the CT scans and the request. Usually we first find out about a screening examination through the order in our electronic medical record system. Our program coordinator will pick it up there. But we don't stop at that. We contact the patient every time because we have to schedule a time for when the patient gets scanned. So when that coordinator talks to the patient, she will confirm that the patient is eligible. And occasionally they're not. Occasionally there's misinformation on the order. And then she'll also make sure the patient really understands what they're getting into, and sometimes they don't. I don't recall a patient where once she explained it to them, they said, no, I don't want it, now that you tell me what's really involved. But there were patients who didn't know really much what they were getting into at all when she did it herself, when she just told them about what the benefits and harms were.
Thanks.
Denny, I would just respond that I think in the real world, I think that both aspects of shared decision-making need to be active. I meet with a lot of primary care groups, and I hear a lot of heterogeneity, and some want to do that, feel that they're the best person to do it because of their relationship with a patient, which I think if they have the time and the knowledge and the interest, I think that's correct. Others want to identify an at-risk patient and refer it for expertise in a centralized location to have the shared decision-making, and then whatever management has to occur. And I think both are legitimate. And we have a system, at least, that allows both of those, either one of those things to happen. We can do the shared decision-making as a program and direct patients out of the program if they don't qualify, or accept patients that go through the EPIC order and shared decision-making with their primary care physician.
Yeah, it's just, I think it's a major problem. Determining eligibility and actually having referrals for patients who are ineligible according to current criteria is not a trivial problem. And although I'm not Marcus Welby, I think I'm adequately trained and understand the screening process well enough to be able to do informed decision making, and I may actually do a better job than the primary care provider who wants their patients screened.
And I just want to add on, I know there's a lot of questions, but you know, in our outreach pilot, where we're really dealing with a very different patient population, that's the primary care docs refer to us for the whole conversation. We have the conversation first, and then they go into the specialized center if they make that, just for this reason. And the primary care docs there in that particular arena, they like that, because there's some people they do refer to us that don't meet criteria, and I'm able to write a note and send them back and say, no, this person doesn't meet criteria, but guess what? Smoking cessation would be great for them. Here's our smoking cessation program, and then move forward. But that is not the model that we have, you know, at the main campus. That's a very different way. But I think we, you know, to Doug's point, we can do this in many different ways. We can tailor what we need to do depending on the patient population.
Hi, Andrea Brandi-Kitts, Leahy Hospital and Medical Center. Dr. Wood, thank you for talking about NCCN Group 2. I'd like to make a couple of points. One is that we've updated that study. We haven't published anything yet, but the numbers hold that there is equal incidence of lung cancer in NCCN Group 1 and Group 2. And we've recently started a study where we're doing a retrospective screening registry where we're going to try and collect all the people in the United States that have screened NCCN Group 2 and go ahead and compare them to NCCN Group 1 and get a large enough sample so that with beta of 0.8 we can show that there's less than 1% difference in incidence between the two. Leahy has screened almost 1,000 NCCN Group 2, and there's other hospitals across the country that have. So my goal is to get 2,000 Group 2 and then about obviously the same number or more Group 1. So if anyone here knows of any hospitals that have NCCN Group 2 data, patients you've screened, we have a REDCap database we've set up as a registry. We have Leahy IRB approval. Obviously, you'd have to go through local IRB approval. It's all de-identified data. So I'm sending a call out for information and data. Thank you.
Well, that's terrific that you're doing that follow-up, and I look forward to seeing it. Brady McKee and your group have been doing a great work in publishing it. And one of the things that I appreciate about our annual update process is we get a chance to look at this every year and revise it if there's new data that can suggest that we're wrong and there's something that we ought to change and what those recommendations are, or that validate the position. So far we felt validated, but we also recognize there might be data that suggests we've got part of that wrong, and if so, we'll revise it.
Thanks, Andrea, for that comment. You said that there's little difference between the two groups, and I'm just wondering how big the two groups were. They sounded like about 1,000, but how many lung cancers have you actually seen in the two groups for comparison?
Okay, I don't have the exact numbers in front of me. I can get them for you, but about 25% of our patient population were NCCN Group 2. So at the time, the last update, I think I had around 600 Group 2, and then 1,000, 1,500 or so Group 1. And the percentage of lung cancers was the same in both. It was around 3.6% or so. I'll get you the exact numbers. So, and then while we're talking, Dr. Tamamaji, I just wanted to also comment that, as you know, as my MPH master's thesis, I just finished an analysis of the predictive performance of your PLECO M2012 model in the Leahy lung cancer screening population, and it did show fairly good predictive performance. Our AUC was 0.635, so that's not as good, but it's a different population. So thank you.
Thank you.
So I'm going to interject just for 1 second because we are standing between people and their lunches. So maybe since we have two people who have been waiting for a while, if you can promise to keep your questions and answers to under 1 minute each, and we can get it wrapped up.
I guess I'll go first. So I'm Ella Kazzerny from the University of Michigan, and my question has to do about assessing capacity and the growth of lung cancer screening in the U.S. So for breast cancer screening, we're at about 70% uptake, and for colon cancer screening, if you include everything, we're at about 60% screening. And if you drop out fecal occult blood, we're probably down at 30 or 40%. What, in your expert opinion, is the estimated uptake rate going to be of lung cancer screening? Because when I hear capacity described, I hear it as almost all or none. If we were to screen everybody today who qualifies under USPSTF or different coverage decisions, it would be X. But that doesn't take into account the uptake rate. We certainly have things in our favor like internet dissemination as a media that we didn't have when lung and colon cancer screening started. But then we have other things like shared decision making and trying to implement and understand how to do that effectively. So what are your thoughts?
I used an estimate of 75% take-up as my base case. I think I've seen other projections that use slightly lower percentages, maybe 60, 50%, 70%. Those are sort of my arbitrary opinion as a health economist trying to sort of come up to some roughly reasonable number. I mean, one could consider that there will be fewer advocacy groups pushing for screening, likely for lung cancer screening, than we see for breast cancer, for cervical cancer screening. That could reduce the rates. Particularly, screening is concentrated among more disadvantaged populations, lower income, lower education. That's where the smoking burden is right now. I would imagine that will drop down overall take-up. So my guess is it might end up lower than we see for other cancers. But
I guess my question is more the annual uptake rate. You know, if we start with the base case of nobody's getting screened, you know, next year is it going to be 3% of the appropriate population, and then is it going to 5% and 7%? So as we talk about building capacity, it's not all instantaneous that it exists for whatever percent we think we're going to get to.
yeah, no, that's a great point. I sort of based it off of sort of instantaneous capacity, but actually reasonably it'll take a while to get there. So maybe we have time to sort of build that up to meet our targets. But I would expect that it will go more quickly, perhaps, than the previous cancers because screening is sort of just more mainstream now as part of cancer care. And the guidelines are out. Everything is sort of perhaps on board. Whereas for the earlier cancers, it might have been more of a sort of progressive sort of movement towards the current rates. But I don't know if you guys have other thoughts.
My own impression is talking to different organizations and institutions is that they've been surprised at how slow the uptake has been. And in fact, in many institutions, they've not had to buy any more CT machines and bigger infrastructure. And so there's been more gradual growth, which has been acceptable and easier to handle.
Can I still have a minute? This is Bob Smith, American Cancer Society. I want to follow up on this. First of all, the ACS guidelines principally are focused on the quality of imaging centers. I mean, we don't have multidisciplinary treatment of diagnosis and treatment for hardly any cancers around the country. The emphasis principally was on the kind of ACR accreditation, Lung Cancer Alliance Centers of Excellence. We don't want the kind of things that we can get in a Groupon where you can get a scan for $19, and which is one of the ones I got. To your point, though, I think that the analysis you're doing is really important because we don't do that kind of thing today, where we highlight where there are capacity shortages. They exist in mammography. They exist in colorectal cancer screening. No group is responsible for taking a look at the geography within a state and saying, how are we collectively going to meet that need? So to the degree that we could start adopting a principle like that, then this would be a disparity that could be overcome readily by just determining how do we bring the capacity to these underserved areas. Now, to follow up on your idea about blood tests, Septin-9 was not approved by the task force. In fact, the data, more recent data hadn't been out, and while they talk about it, it's not on their list of recommended screening tests. Doesn't mean it might not have some use, but the fact of the matter, most serum tests tend to be expensive. They tend to be influenced by tumor burden, which means they're going to be better at picking up big cancers and small cancers. They have lower sensitivity, lower specificity, and you still have to image or scan or scope the patient to see if a cancer is there or not. So ultimately, I think you are going to have to build basic capacity for screening one way or another into all of these underserved areas.
I'm sorry that we went over, but I think it's because we had such great discussions and questions. Thank you very much.